Thank you so much, Dr. J. Raja and Dr. Baker, for this kind invitation, and thank all of you for being here. It's always hard to follow Dr. Jimenez. He is such a visionary and really can see, and he marries all of our skills together. He does percutaneous, laparoscopic, open surgery. So I just want to say it's a hard thing to follow him. I'm going to talk about contrast-enhanced ultrasound. I was given the task to speak on ultrasound advances, and I think that we've already talked a bit about training and education, of course, having some of those basic skills. This is going to be my 7 seconds for absolutely zero disclosures, empty pockets. Education and training is, of course, really very, very important. And if you want more training in ultrasound, please speak to any of the people up here on the panel. So what is ultrasound contrast? Anybody out there that I can see blinded by the light? Anybody out there using ultrasound contrast? I see no. Yeah, I'm not surprised. Well, no, I'm actually not surprised at all. Dr. Jimenez has used it. So ultrasound contrast, what is it? They're essentially microbubbles that range in size from 1 to 5 microns, and they stay intravascular. They're basically microbubbles that are encapsulated by a shell, and that shell allows for different harmonic frequencies, and you can create different contrasts with special probes and special software so that you can see vascularity very, very well. So why is it that none of you are using it? For those of you who do liver ultrasound, probably because in this country, in the United States, it was only in 2016 that the liver-specific contrast agents became available and approved for use. And that specifically is Lumicin, although it has been used in Canada for a number of years, and it's also been used in Europe for a number of years, and also in Japan. Sonacid is the other agent that is not available here. So most of what I'm going to show you, although there's going to be some mixtures, but what we want to learn about, if we want to include this in our armamentarium, is to be acquainted with Lumicin, also by the name of Sonoview, manufactured by Bracco. So how do we use it? Well, what did I say previously? You need a special probe, you need special software, and you also need to know how to set your ultrasound system. So the power outlet, so there's power and then there's gain, right? So power is the ultrasound wave or energy that is emitted from the ultrasound system. It emits a mechanical index. You want to keep that mechanical index low, because if you don't, and the reason I'm telling you all of this is because of my mistakes, right? So if that mechanical index is too high, then it will create destruction of the microbubbles. So why am I telling you this? Because you need to know how to use the product to get the most out of it. So your mechanical index you want to keep low. Normally it's somewhere 1.5, 1.8, so you want to bring it down to somewhere around 0.1, okay? And that's really important. So this is what it looks like. This is hopefully this plays. Yes, it does. So this is an arterial phase. This is only the ultrasound contrast image. And if I can play that again. So you see this is the tumor, obviously. And this is that it's hypervascularity, or that brightness that we see with lesions that are hypervascular. So just like in triple phase contrast CTs, we also do the same timing when using ultrasound contrast. Clearly, one of the challenges is identifying the tumor, localizing the tumor, and then watching it under these various phases. So the portovenous phase and the delayed phase are a little bit different as opposed to CT, but the arterial phase is up to 45 seconds, and you see the portovenous and the delayed phases. All really important. Again, when you're visualizing a tumor and you're trying to identify perhaps areas of vascularity of a tumor, or essentially what is the diagnosis. Now, this is the typical view that you want when you're using ultrasound contrast enhancement. So you'll see over here, this is the typical B mode image that you're going to have. And so this dual image, this is going to be your contrast image. So let me play this, and what you see, and I'm just going to stop for a moment. Now, I don't really see too much, but there might be something here because I can see a little rim of something, okay? As we inject the contrast, you'll see, and we're kind of moving around because we're trying to figure out, well, is there something there or not? And as I'm moving around, I'm looking at once, I'm going to stop it here, and you see here is the contrast enhancement. And so this is arterial phase. So you see in this view here, we do see there is a bit of a hypoechoic lesion to the eye. So we can see, again, this is a lesion that is bright on arterial phase. So this is the typical view that you're going to want. As we move on, then we also have the portovenous phase. Now, just like in typical hepatocellular carcinomas, we have early arterial enhancement, portovenous washout, same thing with contrast enhancement. And we'll talk a little bit about, well, how do I tell benign versus malignant tumors? One tip that I just want to give to you is that when you are scanning in the portovenous and the delayed phases, you don't want to constantly be on top of the tumor because the microbubbles will burst. So you kind of want to move the probe around. So many times if you're looking at videos, that's the reason why the probe is always moving, okay? Because we don't want to be right on top of the tumor. So this is a delayed portovenous delayed phase, and you see how it looks black, right? These images are reversed. So we've got the B mode over here, and we have the contrast enhancement over here. But you see earlier and here, looks black. Okay, so that is washout. So how do we tell the difference? General rule, benign lesions, we have no washout or they retain contrast, just like in CT. We all know this. In malignant, we have washout. This is a very busy slide. Just gives you an idea of what we see in the various types of benign lesions, hemangioma, FNH, and angio and adenoma. And then in hepatocellular carcinoma or metastasis, so we see a brightness, right? We see a brightness. The metastasis can be variable in their arterial uptake, but typically we have that washout in the portovenous phase, and that will differentiate that from benign tumors. So this is the one of the points that I really want to drive home to folks is that difference in the portovenous and delayed phase. So just like in CT scanning, we see a typical hemangioma. Here is arterial. We see that enhancement at the rim, and then we see eventually filling in. And this is a schematic of what you typically see. I'm going to go through some of these slides quickly. I wanted to go back. Nope. Okay. How do we go back? This one? Okay, sorry about that, everybody. All right. So focal nodular hyperplasia, typical stellate scar, what we see on CT, and then adenomas, again, same thing. We see kind of like it's not a homogeneous uptake you see in this particular slide. However, we can see that, and you see that it's kind of grainy and spotty, and then it fills in, and then it will typically retain that contrast there. Malignant tumors, I already spoke about this in regard to early arterial uptake here, and then we have washout here. So how do we use it in the operating room? We can use it by identifying lesions that are hard to find. Who's been in the operating room and you're trying to find a liver lesion and you can't necessarily see it under ultrasound? It's happened to me a few times in my life. This will absolutely come in handy if you're trying to identify lesions that are hard to see. Clearly, not every single lesion is visualized under ultrasound. We know that. There are some isoechoic lesions that we can't see. This is where contrast can come in handy. It also can identify new lesions, and there's plenty of literature out there, and I don't have time to review all of it, but there's plenty of literature out there substantiating the importance and the use of intraoperative contrast enhancement in identifying new lesions and also changing the strategy. Just another tool that we can use in the OR in addition to ultrasound. It also can guide needle placement, so think about those lesions that you can't see well. Utilizing contrast enhancement will also help, and I'll show you a little trick in really visualizing the needle a little bit later in the talk, because the needle is not seen well under the contrast enhanced image. And of course, it can confirm ablation. So this, I'm just going to give a shout out to Dr. Sakandi, who I kind of saw at my periphery, who is preparing an excellent textbook on robotic liver surgery, and this is a figure from that book on ultrasound. So how do we use ultrasound in the operating room? This is just a conceptual framework. We use it to confirm what we know, define what we don't know, to decide what we're going to do, and then also to guide our procedure. And this also works well with talking about contrast enhancement. So let's talk about a particular case. So here's a 38-year-old woman who is undergoing colectomy for colon cancer. Ultrasound is done, and so we see, and we knew about this preoperatively. She had this on her MR. She had a lesion in segment 6, and this is under B mode ultrasound. She also had, she was also found to have 2 other lesions that were not identified under MR. This is in segment 1. So how can we use this? Here's, we're, go back. So, there we go. So giving her contrast and seeing this light up here, we've got early enhancement. And then again, knowing that, and you can see this even better here, knowing that washout is one of those criteria for malignancy. Here we see washout, and here it is under B mode. And again, it's helpful to have that dual image to side by side so you can compare the two. So we have another case, a 54-year-old who's got a hepatocellular carcinoma on hepatitis B, planned laparoscopic tumor ablation, and under ultrasound, it's difficult to see the lesion, so we use contrast enhancement. So here we have, and this is that image earlier that I showed to you. Kind of hard to see this. We give them contrast, and we can see this well. So how can we use this? I'm going to stop this for a moment. So how can we guide our needle into this lesion effectively? I'm sure Dr. Jimenez has a lot of tricks up in his bag to localize this lesion and to target it effectively. And what I would recommend if you're using contrast enhancement, you can use a little bit of that contrast on your needle. I always target my lesions using a really thin needle, a HPB needle, just because I can stick it anywhere and not worry about hitting something that I shouldn't have hit, right? So I use a HPB needle first. Those HPB needles, you can draw a little bit of contrast up into the needle, and then you'll be able to visualize this. This is actually a technique that I've learned from radiology colleagues, and they have published on this. They call this the light stabber effect. And this is actually what you see. So here's a lesion under B mode, here's the delayed phase, and you see drawing that contrast into your syringe, you can see the needle under ultrasound. And then, of course, you can see the completeness of your ablation. So just a couple of tips. Number one, plan ahead. If you want to add this to your armamentarium, which not many people have right now, plan ahead. You got to get pharmacy involved. Anesthesia has to be on board. They have to know how to give it for you. Make sure that you have the appropriate software, the appropriate probe and settings. Have extra contrast vials available. Again, I give you all these tips and tricks because I'm talking about my errors and what I've learned from using contrast. And intermittently scan during those delayed phases like we talked about earlier. Use that light stabber effect for needle guidance when you need it. And then you also need patience. I took an informal survey from some of my HPB colleagues who have used contrast in ablation, and most of them say that, oh, it's not very helpful. It's because we have to wait. We have to wait, something that none of us really have. We don't have patience. We want everything to be done, but you need to wait at least 10 to 15 minutes post-ablation to be able to have all of that fuzziness clear, right? And so you can see areas of persistent vascularity. Thank you so much. Appreciate the opportunity and the privilege of the podium.